So I'd like to welcome all of you to our CEC Quarterly Network meeting for December 2021. Year's almost over, just about. So I want to wish you merry and happy holidays to everyone. Hope everyone's having a festive time and celebrating safely. So we're going to go ahead and get started. We do have a full agenda here for this meeting. I would like to ask Julie, is it Crisco? She's a nurse practitioner from Bristol Hospice. She will be our first presenter. And like I mentioned before, if we can have our microphones on mute so we can allow the presenter to speak freely and without interruptions. Thank you. All right, Julie.
Good morning.
Morning, Julie.
My name's Julie Crisco. I am a palliative and hospice nurse practitioner here at Bristol. And in late September, Bristol started a new palliative care program that is actually mine. I work with a physician, Dr. Farham Shah, who works with Dignity, and him and I are managing the palliative care program. It's kind of been a slow start, but we're gaining traction and moving. So I kind of wanted to just highlight in a quick PowerPoint for you guys what the difference between Bristol's AIM program, which AIM stands for Advanced Illness Management, but it's also what we are considering to be our palliative care program. Next slide. So Bristol Hospice, hospice is pretty well known by most people. It's the model that we provide for patients when they're, having or have been informed of a life-limiting illness or injury. Hospice is really more not focusing on the cure or to resolve the issue, but more the comfort and care for the patient. And we are trying to palliate their symptoms. That's kind of where palliative care and hospice get kind of intermingled. So that was part of the reason for this presentation. But members of the hospice team visit regularly, and it's a pretty robust team with hospice. They get visits from skilled nurses, social workers, chaplains, home health aides. All those disciplines come to wherever the home is for the patient. And trust me, I've been doing this is going on over 16 years. I've been in hospice. We've taken care of patients in hotel rooms. We've taken care of patients in sheds, outside, out back, behind primary residence. I mean, home can be anything to anyone, any facility, any location. But our goal is to really allow them to access their Medicare hospice benefit and to be able to get the support that hospice provides, especially in what we consider their last maybe 6 months, a year of life. The best thing about hospice, in my opinion, is they have access to staff 24/7. So you have a nurse on call and available to come and make a visit if that's what's needed, or answer questions, or do whatever the family needs, 24 hours a day, 7 days a week, okay? Members of the team, like I said, include the people that go to the homes, which would be the social workers, the nurses, the chaplains, the home health aides. But behind the scenes, we also have volunteer services. We have bereavement coordinators who are gonna carry that family up to 13 months status post death of the patient. And then we also have, obviously, our physicians, community physicians and hospice physicians who help us to manage these patients. Next slide. So as I said, services that are really focused for hospice would be the pain and symptom management. I consider it a true service failure if we've had what I would say an unsuccessful end of life experience would be somebody dying in pain, somebody dying with uncontrolled anxiety, somebody dying with something that we haven't been able to manage. The services we also provide are assisting the patients with emotional, psychosocial, and spiritual, with with being given a terminal diagnosis or the news of imminent or death, there comes all these other components much beyond the physical aspects, but the psychosocial and the emotional and the spiritual. So that's why the robust team is there to be able to help support all those things. We provide any of the medications, any of the supplies, any of the equipment that the patient would need to be wherever their home is, again, and be able to sustain as much comfort as possible. We assist and provide education for the families, staff, caregivers, whoever those people might be, to be able to have the knowledge to be able to safely care for their loved one and knowledgeably care for that loved one. We do provide short inpatient stays. It's called respite in hospice. And we're contracted with a multitude of skilled nursing facilities. And now, well, that's for general inpatient, but for respite, we have contracts with facilities, and we can actually relocate that patient for up to 5 days for the families, just to give them a break and a time. Sometimes families need to travel, sometimes they have weddings, they have other things going on, and they can't identify a caregiver. So we can provide up to 5 days of respite for that patient. And then we also can provide, obviously, and do provide bereavement and counseling services for surviving family and friends of patients. Next slide. Some specialized services for Bristol and hospice would be, we do physical therapy. We contract with physical therapists who can come out and really not to do not to strengthen or to rehab the patient, so to speak, but more for things like Hoyer training, fall risk education, transfer education. So if there's family members who are new to caregiving and they feel really uncomfortable because grandma or their father is no longer ambulatory, but they want to be able to safely transfer the patient from hospital bed to wheelchair, we can provide a physical therapist to come in the home and provide that education for them. We also have massage therapy. We have Sweet Dreams, which Sweet Dreams is a program that is specific to Bristol, where we have aides, home health aides, who come into the facility and or home in the evening hours and do light touch. They can provide some aromatherapy, some calming things, and it's really beneficial for our Alzheimer's patients or patients who have sundowning to be able to have somebody try to help relax them in the evening hours to be able to allow them to sleep better. We also have a very specific program for Bristol called Bright Moments for our hospice patients. And Bright Moments is a box. It's a toolbox of really great things for, again, that Alzheimer's population or dementia population. With some, there's a weighted blanket in there. There's a teddy bear. There's an MP3 player, and we coordinate with the families to try to figure out what music would be best for the patient. There's some assistive devices for them, like cups and spoons, and it's just a whole packet. And what we do is we incorporate the team, the nurse, the social worker, the chaplain, the aide, in introducing the items of the box to the facility and or patient to help, again, provide better care for those with a cognitive decline. And then we also have a fair bit of trained volunteers who do in-home support. We have administrative volunteers. We have quite a robust volunteer department here at Bristol, which helps support all of us. Next slide. So who qualifies for hospice? Hospice really is for any person who has been given a life-limiting or life-threatening terminal diagnosis. Most reimbursement sources require a prognosis of 6 months or less if the illness should run its natural course, or what physicians, based on information, what they think prognosis would be for this patient. All hospices consider the patient and family together as a unit of care. Next slide. Hospice is paid for by, like I said, most frequently the hospice Medicare benefit. So patients who are Medicare eligible, hospice is paid for 100%. And nowadays, most commercial insurances and Medi-Cal also have hospice benefits to be able to provide. I think there's been enough research to prove that hospice is a cost-effective healthcare route for patients. It keeps them out of hospitals, it keeps them out of doctors' offices, and to be able to get the support that they need in the home is extremely beneficial. We here at Bristol don't bill our patients for anything. Bristol has a foundation that helps support our underinsured or uninsured patients so that they can still get hospice services. And our foundation actually pays the company to be able to provide services for those types of patients. All right, next slide. Bristol Aim. So this is our new palliative care program. It's AIM stands for Advanced Illness Management. This is my new project. We started, like I said, in late September. It was kind of a slow roll, but November picked up, and so far December's rolling pretty good too. I think I have about a dozen patients on this program and a couple that I have admitted and transferred over to our hospice. But palliative care and chronic disease management is designed to meet the complex and dynamic needs of our patients and families and caregivers. Our program is truly an interdisciplinary approach, utilizing the physician and the nurse practitioner. We do have a social worker who we've contracted with, and I have a chaplain who I can also use as a resource if needed. They're not part of the primary team, but I can get their support. Our providers develop a detailed plan of care designed to address symptom management, pain management, quality of life, and advanced care planning. One of the focuses of my intakes with these patients is advanced care planning. We discuss the POST form. We talk about goals of care. We address all those things. And if it's not a situation where I feel like that's something that we can discuss on the first time I meet them, then we don't. I let them know that that's something that I anticipate having a conversation with them about, but we can do that at a later meeting. Next slide, sorry. Bristol Palliative Care Services provide really an extra layer of support for our patients by managing their symptoms, providing disease-related education, conducting goals of care and advanced care planning discussions, and ensuring that the patients are receiving the right level of care at the right time. Really, it's to support those patients who may be not medically eligible for hospice at this time, but probably could be in the next 60, 120, maybe 6 months even, but they're needing a little bit of management, extra layer of support. I do make regular visits, and my visit frequencies are really based on the needs of the patient and their symptom management. I have a couple patients that I see every other week, so every 2 weeks. And then the majority of my patients I see monthly, but I can even prolong, if they're pretty stable, I can even prolong my visits to every other month as opposed to monthly. The Bristol Aim team strives to enhance the patient's quality of life and to coordinate care. And I work and communicate with community physicians. I'm by no means trying to take the place of their primary physicians or their specialists. I'm just an extra layer that's going to be able to come to the home to help coordinate all of that care. And I do communicate, like I said, with those physicians regularly, especially after my visits. I usually fax over my notes and then send them an email or text message. Most of the physicians I know how to communicate with, and let them have my phone number so that if they have concerns for their patient or whatever, they can communicate directly with me about that. Next slide. So who qualifies for AIM? Anyone who has an advanced illness or a serious illness could benefit from this layer of support. Patients who would like a specialized symptom management team coming into their home, patients who would like someone who specializes in having goals of care conversations. I will say it's sometimes not in the time schedule for physicians to be able to have these goals of care conversations with families and patients. And it's something that I can do. I can be at the bedside. I can wait and plan that meeting for when the sister and the brother and the niece and all these important people to them can be in the home so that we can have a group conversation. And maybe we don't figure anything out, but I can present education and then go back and we can have a give them some time to think about it and address those things. And then I can go back into the home and we can start working on what are the next steps to be able to allow the patient to be able to make their decisions about their goals of care. Or patients that would like a provider to just help coordinate. Sometimes patients have multiple specialists and they just are like, this doctor doesn't talk to this doctor and this doctor doesn't talk to this. And so that's part of what I do is coordination of care. Next slide. This is my last slide. How is AIM paid for? So right now, because it's a pretty new program, I only am able to, I bill for my visits, but I'm only able to bill Medicare patients at this time. So we're working on getting letters of agreement, some contracts with some private insurances, especially the ones here locally in Bakersfield. Those things will come as time goes on. And like I said, even with just the Medicare patients, I've been rolling about, I've admitted about 15 at this point, and it's gone really well. I'm getting positive feedback. So if you guys know of anyone or want to have a conversation, feel free to reach out to me. I can leave my contact information with this group. Any questions, comments, or concerns? I have a question
Julie,
for
we
you,
do have a
Julie.
question here.
Yeah.
Let's see. It says, hello, Julie. Who do you contract with for GIP? Is that it? Let me see. Yeah.
For general inpatient, right now, we have general inpatient contracts with Adventist Health and nursing home facilities, a couple of the skilled facilities here in town.
Great. Any other questions? I don't see anything else in the chat. Well, thank you, Julie. I know it's a tough subject, end of life and palliative care, and but the work that you do to make it, persons going through the end of life stage, to comfort them and to provide that pain management, I think it's really very beneficial. And I think also the other services that you provide to the family to have them cope with their family member that's reaching the end of life stage is going to be, it makes it a little easier to go through. So thank you, Julie, for those services. Yeah.
Rodrigo, I'm sorry, it's
yes, Nancy.
One question here for Julie. You mentioned that the program covers potentially clients that are uninsured or underinsured. Would clients that are at this point do not have a satisfactory immigration status, would you be able to help them as well?
Yes. Mm-hmm.
I appreciate it. Thank you. One more item to add to my resource binder.
Yeah, for sure.
Yes, as you know, we help clients for health insurance, but we also are always looking for client services out there in the community that could potentially benefit or help clients that are under no satisfactory immigration status.
Thank you. Yep, for sure. Thank you.
Thank you, Nancy. Thank you, Julie. We're going to continue our meeting this morning. We have a presentation from the Henrietta Weil Memorial Child Guidance Clinic, and the Adult Behavioral Health Services. We have Christine Perry, and Christine, I know we were chatting here, but we did not receive the PowerPoint. So I think what we could do is we could share your screen. If you have that PowerPoint up on your computer.
Yeah, let me. All right, here we go. Can you guys see it?
Not yet.
Okay. Oh goodness. There we go. All right, how's that?
Yes, we can see.
Okay, perfect. All right, so my name is Christine Perry. I am the program manager here at West Brief. We are in a kind of a season of transition right now. We're, as I'm coming into program manager, our program manager is going out. So I will give you as much information as I can today. So we are a nonprofit private outpatient mental health service that we participate with both children and their families. Why is it going? Sorry about that, guys. I'm going to stick right here. So we are like I said, we're working with children and adults. So we can service technically ages 0 to 21, but we do find that most kiddos under the age of 2 don't necessarily benefit from our services. A lot of it then becomes age appropriateness unless there's some extreme trauma, things of that nature going on for them right then. And we've been providing services since 1946. The founder's children her daughters were the one that kind of began this so that they could continue serving the children in our community for mental health needs. So we service families that have a large range of concerns. So we're talking about significant emotional or behavioral concerns. Oftentimes these are a result of sometimes like kind of normative life experiences. Maybe there's some sort of trauma in the family, like a divorce or a loss of a family member, and maybe the kiddo isn't able to manage it as well as kind of we'd like them to. So then they can come over here and we can help them with skills in that. And we do a lot of work with kiddos that have some extensive trauma, loss of parents, living with guardians, things of people of that nature. So we have the kids they're being referred to the clinic because they have some significant functioning issues at home or at school in their community. So basically they're not working with the school as well as we'd like them to. Maybe they're failing, maybe they're unable to kind of participate in classroom. And oftentimes they've been removed because of behaviors that they're experiencing or presenting within the classroom. We're also working with kiddos that maybe aren't able to engage with their peers or their family in kind of a normative way where we want them to start building those relationships, and they're unable to do that for various different reasons. As far as our referral source, anybody can refer themselves over here to us. So we are a walk-in clinic and we'll serve the entire community. That means you don't necessarily need a referral. The families can walk directly in and receive services from us. But some of the people that we do often receive referrals from is various psychiatrists in town, a lot from primary care doctors. When the kiddos go in, they will be filling out a form stating what's going on with them. And there's some, mental health questionnaires involved in that. The doctors will find that there's some concern about what's happening with kiddo, and then they'll end up referring them over to here. We have a lot of referrals from school staff, but our primary source of referrals really is caregivers and families. So like I said, they can just walk right in, and I'll talk a little bit more about that in a minute. So the process that we have going on here at Child Guidance is that once we receive a referral or the family calls in, the family is instructed to come back and utilize our walk-in services. And what that means is that our doors open every morning at 7 a.m. Monday through Thursday, where they are then served kind of on a screening assessment on a first come, first served basis. If for some reason the family is unable to utilize this walk-in service, we do have opportunities for scheduled treatment or scheduled assessments and screenings, but we really do like to utilize the first come, first serve. It just makes things run smoother for both us and the families. At that time, we'll be gathering some basic information on the youth and family, and then they're asked to come back at one of the scheduled assessment times during the day. So sometimes that can be as early as 8 in the morning, but sometimes it can be later on in the day as far as 4. During the assessment, which is our next step, we do an assessment and treatment plan. The caregiver and the child will be sitting with a licensed therapist, and then their purpose then is to determine if there's a qualified diagnosis. We are fully funded by Medi-Cal, and Medi-Cal does require that they have a qualified diagnosis, and that means that we're looking again for those significant impairments that often happen with the kids, and how they're affecting their day-to-day life. And so once we do that, we can then talk about what treatment and diagnosis looks like. However, if there isn't a qualified diagnosis, then we are fully capable and ready to provide referrals that might better suit or be more appropriate for the family here in our community. And some of those include some like grief counseling, and we often utilize like Hospice, a lot of ABA services here in town, maybe a lower level like community therapist. And when I say lower level, I mean there are levels of mental health. And for us to provide services here at the clinic, the kiddo needs to be level 2 specialty mental health or higher. And so if we have a level 2 where there no specialty mental health is required, then we would send them to one of our community providers. We often utilize CSUB, their training clinic over there, for families as well. It's a great resource for us. And we do work, and COVID has kind of put a halt on some of this, but we do really work with community groups and events as well. So sometimes if a kiddo comes in and they don't have a support system, we want to encourage that. Maybe that's the kind of primary thing that's going on in their life. Maybe they don't need ongoing services, but they need to be connected to resources, and so that becomes a really positive way that we can provide that for them. And so once we have a qualified diagnosis for treatment, then we meet the family will be referred to one of our mental health workers here at CGC, and they will design a course of treatment that includes like family, individual, and some instances we do have some groups that are happening here. So we have a few of them to mention off the hand is we do have a dino group, which is for kiddos ages like 3 to 6, where they're working on social skills and anger management and things like that. We have teen groups. We have lifestyle groups. We are in the process of working on some of those more, preteen kind of anger management groups. Like I said, COVID kind of has stopped some of those groups, but we're at the point where we're starting to slowly bring them back. One of the things that we're going to be working on over the next couple of months is just really kind of like a life skills group and the bringing back the family support groups. So we have 2 different types of family support groups. One is where we let the families come in and we just kind of monitor it and kind of sit back and let the families support each other. And another one is where the therapists will be actively involved in that group, where they're providing coping skills and parenting skills to the family. So some of the program guidelines that we are a brief solution-focused mental health program. And what that means is that we're identifying specific, measurable, attainable, and relevant goals for our clients and their families. And we want to set a reasonable timeline for these goals. So the reason that we do this is we want to reduce those mental health services, reduce those mental health symptoms that the youth might be experiencing, but we want to just make them manageable for the family. We know that we're not going to be able to extinguish all of these symptoms and all of these behaviors that the youth might be experiencing, but we really do want to make them manageable for them. And that means that we would provide the families with the coping skills, with the resources, and whatever tools that they might need in order to be able to address anything at home that might come up later, or if the symptoms start returning and that sort of thing. We also do remind our families that once they've been in services with us here, and if they've been discharged and linked to community services, that we do allow for them to come back. one of the things that we share with them is that treatment guidelines say that 6 to 9 month treatment episodes with a break in between, without us overlooking our kiddos and kind of telling the family, let's do this or let's do that, but giving them an opportunity to practice the skills that they've learned at home without us. And then it works much better than us just having really long treatment episodes. In some instances, longer treatment episodes can be found, they kind of start reducing the gains, and it no longer becomes beneficial to the client and the family. So our treatment does last on average 4 to 6 months. And that doesn't include any kind of high risk behaviors, any kind of crisis and behaviors, any kind of like danger to self or danger to others or extreme trauma. We do hold on to those clients for longer, and we work on transitioning them sometimes into a higher level of care. So for access to our services, so we do serve youth up to the age of 21. We generally don't have clients over the ages of 18 or 19. So we can serve them up to 21 as long as they're in school and meet the criteria. Oftentimes, if they're 18, 19 years old, they're still living at home with family, they're with their caregivers, they're in college of some sort, or maybe they're still working on getting their high school diploma, and they're experiencing some significant symptoms, and so we'll continue working with them. But during that time, we're only working towards kind of providing them coping skills, stabilizing them, and getting them into an adult system of care that can help them with different resources to meet their needs at that time. So again, no referrals are needed for us. We do, of course, love referrals in the form of, if you don't have an official referral source, sending us an email or a phone call, kind of talking about it in that way. We do believe that a collaborative approach with our community and the client and other caregivers really helps best suit our families and their needs. So we do appreciate all those things. It is walk-in access, as I said, first come, first serve. We do have crisis and emergent appointments and services available. We do address, we do have various services for high-risk clients. So, if they're in and out of the hospitals, or if they have active suicidal ideation, things of that nature, we can kind of accommodate those as well. And that's not necessarily a walk-in. That would be call us, come in, see us, and we'll get them seen sooner rather than later. We are fully funded by Medi-Cal with a qualified diagnosis. Individuals can private pay, and we don't, sometimes the private insurance can be utilized here, but it's in very rare cases, but we can't provide services for those, or referrals for those that have the private insurance. We are open for face-to-face services Monday through Thursday, 7 to 7, and Friday, 7 to 4. And we provide letters of absence that are for both the youth and the caregiver. So them coming in, we know that it can be difficult, especially with COVID and all this happening. Employers don't often want to give, any more leave, but we do provide letters of absence for both of them. So, and then our contact information is on there if you need it. You guys have any questions?
Thank you, Christine. I don't have any questions right now. I know here in our office, I know Nancy and Cecilia are certified enrollment counselors, to provide services directly to community members, and so they see firsthand sometimes the need for behavioral health services. I don't know if Nancy or Ceci, do you have any questions for Christine?
I don't have any, Rodrigo. I think she gave me that question I needed an answer for, which was what health insurance is available and can they accept there, and it's Medi-Cal. So definitely another resources that we'll keep on utilizing and keeping in mind when the need arises.
Okay, and we do have a question in the chat. It says, don't know if you mentioned this, but after your treatment term, do you refer your clients to agencies for additional support options, for example, private counselors?
Yeah, absolutely. So sometimes we, and I've always called them personally, I call them like tune-ups, right? So if we have been going through mental health services and things are kind of stabilizing for us, and we've developed this support group and these coping skills, and we're able to manage these symptoms with our families. Sometimes we have bad days and we need tune-ups. And so I think that the same thing goes for our kiddos and our families. So we really do make sure that they have referral sources when they are transferred to community care. So we, you know, it's really tough right now to find therapists and counselors in Kern County that accept children. It seems that a lot of them, you know, it's just sometimes something that they don't want to kind of take on. And I understand that it can be difficult and there's a lot of different pieces to it. But we do utilize, like I said, CSUB, and there's a few other facilities here in town that we can utilize as well.
All right, and we have a little comment here, a question. Do you have outreach flyers that you can provide us?
I sure can. I can send that to you, and then you can distribute it if you'd like, or maybe I can drop it in there. I'll have to find out.
And also, is this presentation available in Spanish? Because sometimes we do hold some Spanish-speaking workshops, and
Yes.
This would be a great topic to bring to that community.
Yep. And if you have a workshop that you would like somebody to present out, we do have individuals who can help with that as well.
Great. I really like the way that you presented the process, especially the walk-in part of it for your assessment, screenings and assessment. So it's great. Thank you for providing that information to our certified enrollment counselors here in the community and the other agencies that are on this Zoom call. I think it's great information that you're providing, great service. So thank you very much, Christine.
Oh, of course, thank you.
All right, well, we'll move along. In the past, we've brought speakers and presenters from our programs here at Dignity Health, and this time around we invited Sarah Moore, and she heads the Art and Spirituality Center here at Dignity Health, also part of our Department of Special Needs and Community Outreach. So Sarah will speak to us about the program that she is running there with we don't just heal body and mind, but also the soul and the spirit. So Sarah.
Thank you so much, Rodrigo. Well, thank you all so much for being here today and for all the information that was shared already. So as Rodrigo mentioned, my name is Sarah Moore. I'm the supervisor of the Art and Spirituality Center here in Bakersfield. So I'm going to just give you a quick overview of some of the things that we do here from our center. I went ahead and put my contact information in the chat box. So you guys are welcome to keep that, to reach out if you have any additional questions. And I just actually finalized our next program calendar for January through April of next year. So after this meeting, I'll send it to our Halia and she can email it out to the group so you have all of our current workshops available to you and your clients and whoever you see fit. Next slide, please. So the Art and Spirituality Center, for those of you who don't know, the physical building is actually located here right next to Mercy Hospital on Truxton, near the corner of Truxton and A Street. We were founded in 2010, so it's been 11 years in the making. And what we do here from the center is we offer programs that are intended to provide healing. So we call our programs Art for Healing programs, and we have a wide arrangement of different programs that we offer. So they're not all painting and drawing, although we do have drawing and painting workshops. We have music and movement workshops. So some examples of that would be ukulele. You could see Tammy Varner here in the picture. She's playing her ukulele, and that joy is a result of her workshop that she completed with our music specialist, Kyle Whitaker. And then here in the right corner, you can see two of our regular participants who do our family paint night called Family Fridays. Some movement workshops that we've done chair yoga, we've done traditional yoga, we've done Tai Chi. We do all kinds of handmade creations, contemplative and reflective programs such as meditation, healing breathing, those types of things, and even writing and poetry. So new opportunities and new ideas for these creative workshops come from our facilitators, from our participants, all the time. So we're always trying to keep a good balance of those types of programs. And like I said, the biggest part of this is to be able to provide a creative experience that promotes healing. And just like Rodrigo said, it's not just the physical healing, but it's the emotional and spiritual healing as well. So some other services that we offer through our program to our patients, all of these Art for Healing programs are focused outside of the hospital walls, but we do have a number of things that we offer to our patients here in the hospital as well, including Art Cart, Acoustic Remedies, and Threshold Choir. And I'll go ahead and go into more of those in detail. Next slide, please. So here is a little snapshot of our art cart. You can see on the left our art cart specialist. This is Brittany Rivera. So she goes out with these little kits that she's holding, and she takes the Art for Healing experience to our patients right at their bedside. The art cart serves all three of our hospitals, Mercy, Mercy Southwest, and Memorial. Memorial, because of its pediatric unit, that's where our big focus is. Brittany spends a lot of her time with the kids there, which has been a huge blessing to her, and of course a huge blessing to our patients as well. And we set goals, as all of you know, goals and numbers are something that we have to be mindful of, and we're on track to serve more than 1,300 patients this fiscal year, which is great. Last year was quite different because there was a time when we couldn't have, even our staff couldn't be in the hospital providing these types of services. So we were creating little grab and go kits that the nursing staff would hand out, but we weren't able to provide that personal connection with them, doing those art activities with our patients, introducing the program, helping them experience that Art for Healing experience that we want everyone to be a part of. But now that our employees are back in the hospital, forming those personal connections, it's been really beneficial and really productive. So we look forward to seeing, continuing to see the impact of the Art Cart services. On the right here, you can see one of our recently admitted patients. She was so sweet, and she was so thrilled to have just a coloring book. I mean, I don't want to say just a coloring book. This is actually a pretty special one that has some personal development activities within it. And this gal here, our patient, was so thrilled to have something like that to do in the hospital and help her healing. And then she took it home and was able to complete some of those activities with her daughter. Next slide, please. So this is our Acoustic Remedies team. I call them the Kyles because both of them are named Kyle. On the right, we have Kyle Counter, and on the left, we have Kyle Whitaker, and you can see that he's playing for a patient in the hospital that was here at Mercy downtown. So something unique about the Acoustic Remedies program is this program, funding for this program is solely by employee giving and a couple of private donations that we've had. So we have an employee giving campaign annually, and every year different projects or programs or initiatives are funded through what our employees give. And 3 years ago, the Acoustic Remedies program was one of those programs that were funded, and actually we were able to receive additional funding for the 2022 year to keep the program going. So it's really, really neat just to see the fruits of people's giving and how it benefits not just our patients, but our staff. When our staff hear our musicians coming through the hallways, walking up and down the stairs, playing their instruments, it really just sets the stage for a calm and healing environment. Our staff love it, and our patients have been really receptive to it as well. And our Acoustic Remedies team, it's a team of 2. They divide and conquer, serving both of our Mercy hospitals, and they're on target to reach more than 2,000 patients within the fiscal year. Next slide, please. This is a snapshot of our Threshold Choir, just a couple of them. I think we have a total of 19 Threshold Choir members now. And for those of you who aren't familiar with Threshold Choir, they are a volunteer choir that offers gentle, calming songs to people who are at the threshold between life and death. So the top picture here on the right, this is a Threshold Choir singing at the Hoffman Hospice home. It's their inpatient unit, and they're able to just sit by the bedside and sing to these patients, oftentimes who are actively passing or close to it. But their gift of song isn't exclusive to end of life. They sing at local hospitals, ours included. They sing at local assisted and skilled nursing facilities. They do lots of singing into private residences. They got really creative when the pandemic first started, really having this heart to want to continue reaching people who need their songs. And so they would go to private homes, and the owners of the home would open a window so they could sing outside, socially distanced, and still provide that gift of song while being safe. So that was just really beautiful to see the ways that they continued to offer their gifts when there were unexpected barriers. It didn't stop them. And a couple of our threshold choir members even do songs by phone. One in particular, Anna, she does a 15-minute song session with, she was doing 15-minute song sessions with her neighbor multiple times a week, but now she goes and sings from the patio into her home. So that's really fun. They've come up with a lot of creative ways to connect through the pandemic. And they practice twice a month. And they have been very creative about that as well. They are doing a lot of Zoom practices. You can see this bottom picture here is one of the Zoom practices that they had. And they've done hybrid practices where they've done some in person at somebody's in their backyard and having some people on Zoom. So they're just staying connected. It's been really, really great, like I said, to see how they've been creative. And they will, they offer approximately 100 sings per year with, all those different facilities, sometimes more, as the pandemic has for everybody changed things, but it hasn't changed how passionate they are to offer their services to the community. Next slide, please. So something we were able to do, which is unique, typically all of our services are focused on the community. We wanted to extend an opportunity to let our employees experience the healing benefits of art and creative expression. So we've done a series of employee engagement events throughout the last year, just to be able to spark our employees' creativity, to give them a chance to take a mental health break, if you will, from a stressful environment. I mean, any of you who are working in healthcare know that how it can be devastating and draining and just mentally chaotic sometimes. And so providing these artistic experiences for our staff has just been a really welcome break for them. And it also gives exposure to our programs. With turnover, not everybody knows that the Art and Spirituality Center even exists. So it's nice for us to be able to bring that experience to them so they can in turn tell their patients and families about it. So when we did these employee engagement activities, we did a variety of things. We had our Acoustic Remedies team playing for the staff. We had a mobile Zen den. At the bottom left here, you can see Gwen. She's handing out little daily affirmations, and she would do breathing exercises with our staff. And most recently, we did an activity called Behind the Mask, where we had these masks, you can see in the middle picture here, that people could paint or glue feathers on. They could do paper mache, anything. I mean, we had all kinds of supplies. So that was just a really nice activity for the staff to be able to enjoy these benefits as well. Next slide, please. So it's not just our staff that helps run this program. We have a number of volunteers who make this possible and help our programs to thrive. We have a total of 34 volunteers currently. That includes 19 from the Threshold Choir and 15 through our Art for Healing programs. And just a couple of photos here at the top right, you'll see one of our Threshold Choir members. They were singing in the park and she was having a great time. In the middle, this is one of our music specialist volunteers, Kevin. He plays the ukulele and sometimes the banjo out in the lobbies of our 3 hospitals. And this is one of our volunteer facilitators, Terry. She teaches Zentangle, and this is from one of her Zoom classes that she did. Actually, it was this time last year. They did a word of the upcoming year right around Christmas time for last year, and her word of the year was hope. And throughout the last year, we've had more than 900 volunteer hours contributed, which has been really great. You know, like I mentioned, our volunteers I actually didn't mention this, our volunteers aren't currently in the hospital right now, but they're still finding unique and creative ways to be involved and to volunteer their time, whether it's making a bunch of cards for us to pass out to patients, playing in the lobbies, singing at and facilities, and then offering workshops at no cost to us, which is such a blessing. And on that note, I just want to mention that all of our programs are available to the community at no charge. Anybody is welcome. And I will make sure to get our program calendars out to you guys so you can refer them out and reference them as you see fit. Next slide, please. And this is just a little shout out to our collaborative partners. I know that all of us, you know, we don't do what we do without the help of others. I mentioned our volunteers, but some collaborative partnerships I'd like to mention as well. We work with lots of different organizations in our community and beyond to help make our programs successful, and most of all to help reach the people who need to be reached within our community. So this is just a list of some of the people that we've worked with most recently. Next, actually on Thursday, we'll be at Hoffman Hospice doing their grief support heart art camp event that we do with kids who have lost a special person. So that's something really special that we love. I definitely have a heart for hospice, so I was really excited, Julie, to hear what you had to say because hospice is near and dear to my heart. Also helping these kids heal is huge, and it's really beneficial to see. So, you know, we do typically when the center is open, we'll do workshops from our center, but we'll also take our workshops to where the people are. So we've gone to the M Street Navigation Center. We've done things with the Jameson Center. We've partnered with the ADA KC. We've partnered with a number of different people and are continuing to seek new partnerships to make sure that we're not missing those opportunities where Art for Healing would be a benefit. Next slide, please. So just to give a little shout out to our Facebook and Instagram pages, for any of you who are interested, we are on both of those social media platforms. You're welcome to follow us on Instagram, like us on Facebook, or even join our Art for Healing Facebook group where people will just share their artwork, share tips. We'll talk about things that we have upcoming at the center, but really just a place for people who are passionate about art and healing through art to share and connect. And that's all I have. Are there any questions for me?
Hello, Sarah. This is Marita Jimenez. No questions, but I just wanted to provide feedback. During the pandemic, my daughter, she's 10 at that moment. I told her, hey, you're doing the ukulele. And she did the ukulele class and she loved it. They were all adults and she was the only child, but they were patient with her and they worked with her. And I thought it was great. So just giving you a shout out to the person that helped my daughter that time.
Thank you, Maritza. And can I say something? She was actually in my ukulele class. So I took the ukulele class right at the beginning of the year. I got a ukulele for Christmas, and your daughter was in my class and she was a delight. We all enjoyed seeing her and hearing her. And it was very encouraging for us and adults to see her passion and dedication. So I'm so glad to hear that feedback. She was a joy.
Thank you. And I know that during the time that she took that, that's when our family got COVID. So she's the only one that did not get sick. So it was cute because she would like stand by the door and sing songs to me because she missed me that much. And she sang, I actually have a recording, which I can share with you, Sarah, because it was so touching. She made me cry because it was like she was missing so much that she couldn't hug me, that she would sing to me from the door. It was kind of cute.
That's beautiful. Thank you for sharing that.
Definitely.
Oh, that's great. Thank you for sharing, Maritza. That's wonderful. And we can see how all these programs and our community is so interconnected through all the services that we provide and how we all help to heal our community and make our community a better place to live and make it, more tolerable when the time comes for end of life and things like that. And so just want to thank all the presenters that have provided your information so far. We are going to move on to our Medi-Cal and covered California updates. We do have Tammy Barunda from the Department of Human Services here.
Good morning.
Good morning.
So I'm
yes,
go
go
ahead.
ahead, Tammy.
I just want to, I'm just passing on some information regarding some questions we had that were asked of us. So one of the questions was, are there any changes to lobby hours or the process for those who seek assistance in person at the Department of Human Services? Our lobby hours are 7:30 to 4, and we continue to triage customers out front to optimize the traffic flow and ensure customers are directed to the service areas best suited to meet their needs. We still have the 4 customer service lines. One of the lines is our application line, where an office service assistant remains in position to assist all customers applying for services. They will be advised they may complete a paper application and drop it in the drop box, or they may enter the building and apply in person. The rack of applications and clipboard pens will remain available outside during the soft reopening period, and those choosing to enter and apply in person will be directed to a kiosk number 31. As this line is just for triaging purposes and to provide guidance and information, it should move very quickly. We have a customer service line to drop off documents. An OSA will remain in position to serve all customers who are here to drop off or scan documents. Working from the front of this line, staff will ask each customer if they are here to submit documents and if they have any other business. Those just needing to submit documents will be advised they may use the Dropbox or enter the building to scan. Those choosing to enter will be directed to kiosk 25 to 28. And if they have any other business except business, including renewal packets, SAR7s, or document requests, they will be directed where to go to inside to complete their business. Those needing to be in the renewal packets, SAR7 document requests, or other line will be redirected to that line. And we have a scheduled appointments or applying for homeless assistance line. The office service assistants will remain in position to assist all customers checking in for scheduled appointments or are here to apply for homeless assistance. Those with appointments will continue to be triaged at the front door to determine if they need to come in or use the phone to complete their in-person appointment. Since workers will not be coming out to the lobby to complete face-to-face interviews, the current process will continue to ensure customers admitted to the interview rooms in aisle J are connected to appropriate workers. Those here applying for homeless assistance will be triaged in the same manner as is currently done. And the application will be provided and they'll be asked if they have an active phone. If so, the interview may be done over the phone. If not, they will be escorted to an interview room in aisle J where they'll be connected to a worker. And if an EBT card is needed, they will be redirected where to get it. Our last line is the renewal packet SAR7 and document requests. This line will continue to be worked outside and will not be immediately admitted to the building. Customers in this category generally require more time and a higher level of service to meet their needs, often requiring a case review and interaction with an HST. As such, in addition to the OSA serving this line, a lobby navigator will also work up front to assist in this line, which is a human service technician. To ensure a high level of service, the human service technician will also continue to file clear and assist these customers, and is currently done via direct interaction with these office service assistants. This line includes case review and advising the customer what they need to do regarding verifications, needing to reapply, or redirection to an appropriate service. Schedule an appointment with the worker, identify customer for benefit pickup, issue BICs, the Medi-Cal cards, or request an EBT card, print renewal packets, print SAR7s, or print passports to services. All customers requesting an EBT card will be admitted inside and directed to kiosk 24. Passports requests will continue to be processed by the office service assistants. The kiosks back in service are the BIU. This kiosk has been in service during the lobby closure and will remain in service. The difference being customers needing an EBT will now be admitted directly into the building to request their card instead of the office service assistant escorting them in. The kiosk 25 to 27 are document uploads, and the kiosk 28 to 29 are document requests or drop in to see a worker. Kiosk 30 is an appointment check-in, and kiosk 31 is an application. Customers will now be admitted in to make an application. We will keep enough OSAs out front to adequately triage the lines and to ensure that the lines are moving smoothly. And let's see, that is our office hours and our customer service. So the next question that we had was, we have started to receive updated Medi-Cal renewal packets from clients. A reminder as to this change in how renewals are being processed this year would help. So right now, our Medi-Cal renewals are now being processed by staff when there are no changes being reported. DHCS continues to push out our Medi-Cal renewal dates monthly, and at this time, there is no ETA for when this will end. Clients are encouraged to return Medi-Cal renewal packets completely and timely. The question was, what are the current Medi-Cal renewal packets that the Department of Human Services has in place? I believe 2 packets were going to merge into 1. So right now we do have 3 Medi-Cal renewal packets: the MC216, which is the Magi packet, the MC210, which is the renewal non-Magi packet, and the MC217, which is the mixed Medi-Cal renewal packet. And the last question is, what are some of the items that have been implemented by the county due to Benefits Cal that will help the CECs when assisting with clients? So right now, I'm not sure if we have implemented anything due to Benefits Cal that will assist CECs, but there are a couple of benefits that they can assist clients with, like the ability to use their mobile phone, ability to upload documents. The client can reset their passwords using the mobile phone. Then with the mobile phone, they can upload documents and view what they have uploaded. And they can also upload documents with the actual application, which is new, and check and see who their worker is. And that's all I have. If you have any questions or anything for me, I can pass them on to Gayla and we can get back to you. Thank you very much.
Hi,
Thank
Tammy.
you. Thank you,
This
Tammy.
is Nancy. I have a question. You mentioned 3 packets. Previously, there were 4. Could you please confirm with me which one is the AH blind and disabled? Which one is the one that got moved to? Because we only have 3. So which one of these 3 would be the one that includes the AH blind and disabled? Do you know by any chance?
I want to say it's the mixed one, but I will look into it and we can get back to you on that one, okay?
Okay, I appreciate it.
Okay.
And one question, maybe, I don't know if you might have the answer or if you could take it back. In regards to the RX program, I believe it's starting in January. Would you happen to have any info on that?
The what program?
The RX program?
Oh, the pharmacy, the prescription pharmacy.
Yes.
Okay. I don't have any information, but I can get you some though. And I'll take it back to Gayla. Okay. I promise we'll get you something out.
Okay, I would really appreciate it. We were, I'm sorry, one more question that just came to mind right now. With the Benefits Cal that we have now here in Kern County, would you happen to know what were the changes that our county opted to do? I do know it was based county to county in regards to if maybe someone could be available for all the certified enrollment counselors when they were assisting clients. I know there were going to be maybe a different phone number. Again, it's county by county.
Yeah.
I'm not sure what our county decided or.
Okay. I can find out because I did see that they do have a chat option. They do have a number that you can call option, but I don't know if they've been turned on yet, but I will find out for sure. I'll let you know.
I appreciate it. Thank you.
Okay. Good questions. Okay.
Thank you, Nancy. Thank you, Tammy. We do have another question here in the chat. It says, is there a specific fax number for renewal packets or for clients sending supporting documents? We have had a couple of clients return needing to resend fax due to DHS worker stating they did not receive paperwork.
So we do have a main fax number that I can get for you. A lot of the times they, if the worker said they didn't receive it, we have the email that they can send documents in through too. So, but I will get the fax number, the main one that we're going to be using, and I'll send it all out.
All right, sounds good.
Okay. Okay.
Thank you, Tammy.
Mhm.
Do we have any more questions from the group?
Hi, this is Cecilia. So I just have a comment regarding the renewal packets. I did notice the different numbers on the packets because I believe I've done all three of them, but the packet, it's the same, right?
Yes,
I don't have my
it is the
video.
same. Mhm.
Oh, okay, okay. So it's just like the number is just like for you to see internally, like whether if it's
Yes.
okay.
Yes.
Thank you.
Mhm.
Well, thank you very much, Tammy. Thank you, everyone, for your questions. We're going to move on to Covered California updates. And we have Khalid from Covered California joining us. And he has a PowerPoint, I believe.
Hi, good morning. This is Khaled.
Morning.
I am trying to share my, okay, there we go.
Sorry, Khalid, I just barely gave you co-host capabilities.
No, that's totally fine. Let me see here. Okay. Do you guys see
Yes.
my screen up and I'm circling around it?
Yes.
Yes.
Okay, great, because I have a couple of screens here. Thanks again for having me, guys. I'm glad to be here. For those of you who don't know me, my name is Khaled and I work directly with CCHI regarding the Navigate a Grant program from Covered California. And so for today, we have two main agenda items, but there's going to be several topics to discuss under the updates section, which we'll be getting to now. Before I continue, just want to make sure my voice is coming in okay. I have some background noise, and is that coming in clear?
I hear you. I hear you loud and clear. Thank you.
Perfect, perfect. Thank you. So some updates to the American Rescue Plan are that most benefits are going to continue through to 2022. President Biden's Build Back Better plan proposes extending these benefits through to 2025. The benefits for those who were on unemployment in 2021 are ending, and most of these consumers might see a significant increase in their premiums in 2022 because the ARP benefits for those on unemployment in 2021 were pretty significant. Anyone who has consumers affected by this, who were basically on unemployment, should be reaching out to the consumers to give them a heads up and to see if they want to switch to a more affordable plan. For our navigators and their subs, a list of impacted consumers has been provided, and that report is called the UIB Unwind Report. Also, 100% of COBRA premiums were covered for all eligible Californians just before open enrollment. That benefit lasted only a couple of months, but was replaced by a qualifying life event so that they could get health insurance through Covered California. This qualifying life event ended on 11/29, but with open enrollment, the door is now open for anyone to apply. So those impacted by these high COBRA premiums are still able to get assistance. Governor Newsom is the first governor in the nation to expand full scope Medi-Cal to undocumented immigrants age 50 and over. This expansion is in addition to a fairly recent expansion of Medi-Cal to undocumented children and young adults up until the age of 26. California continues to lead the nation in assisting undocumented Californians with basic human rights, such as health insurance. We know that many people are still uncertain about applying for health insurance due to the concerns around public charge and other factors. But I'd like to reiterate that once again, subsidies through Covered California is not and has never been a benefit that would label anyone as a public charge. In addition, and as a reminder, the public charge rules created by the prior administration has been vacated or voided earlier this year by the current administration. That means that the public charge rules go back to the way they were before the Trump administration changed them, which would only apply to those receiving cash assistance or long-term care. In other words, everyone who is eligible for health insurance should apply and know that they will not be considered a public charge because of subsidized health insurance. Those 50 and older or under 26 should apply for their full scope Medi-Cal benefits. A new state subsidy for 2022 is to add a $1 subsidy to most premiums. One of the purposes of this is to zero out $1 premiums. It would be sad if a plan, were to be temporarily halted or canceled because someone forgot to pay $1. So California is making those plans free, which will ensure that most people will stay covered and not be accidentally discontinued from health insurance. And the final item on this slide is that the state penalty for not having insurance is $800 for an adult, $400 for a child, or 2.5% of the tax filing household, whichever is greater. We always hope that people apply for health insurance because they see its value, especially during the pandemic, and not because they have to. But for those few people who need a little twist of the arm, it would be wise to alert them to the state penalty for not having insurance. And a notice to CECs, some points to talk about. The entering income for new consumers could have a significant impact. So for new consumers, if a CEC creates an application, let's say now, which they'll be likely doing lots of, and enters the client's income for next year to determine their covered California premium, and they do not enter the client's income for this year, the client will be evaluated and referred to the county for Medi-Cal, because the way the system sees it is that the consumer had zero income this year. And again, that's going to push a potentially eligible covered California consumer into Medi-Cal. And we know how messy things can get when cases are stuck back and forth between covered California and Medi-Cal. Therefore, the CECs should be sure to enter the client's information for this year as well. And we hope that these messages get out to all the CECs. It's not a new process, but it's just a reminder during open enrollment so that we can hopefully intercept some of these possible mistakes. The next item is another reminder to CECs that those nearing or aging into Medicare eligibility should be informed that Covered California will not automatically discontinue coverage or subsidies. Their case will continue with any applicable subsidies, and if and until they instruct Covered California to cancel their subsidies or their case. So in other words, if someone is going into Medicare, they really need to reach out to Covered California to have their case stopped, unless they want it to continue. So they can make that decision, because once they become eligible to Medicare, they are no longer eligible to Covered California subsidies. And if they're still receiving those subsidies, they're going to have to pay them back next year on their taxes. And lastly, on this slide, regarding Real Stories, we hope that CECs are continuing to get the message out for Real Stories. Just to kind of quickly summarize, Real Stories is where the CEC is referring to us, to Covered California consumers who want to share their experience for coming onto Covered California, whether they didn't have insurance before and now they have Covered California insurance, or whether they had Covered California insurance but their premiums dropped significantly. Consumers will get their chance for 15 seconds of fame. They'll share their positive experience of obtaining health insurance through Covered California. They'll also receive cash benefits for their time and any possible travel expenses. And it will also shine a light on the referring entity. Not only that, but Covered California is still offering cash incentives to the referring navigator for any consumer who is chosen to share their story. For CECs, the conversation could be as simple as, hey, by the way, while or after the application is over, did you know that Covered California is looking for anyone who wants to share their story? They'll compensate you for your time. They're looking for someone to interview regarding their experience about, coming on to Covered California health insurance. You get to be on camera and famous for a few seconds, add an LOL to it, and we're good. Okay. All right, and then here we have a couple of fairly new reports that we've been providing to our navigators are the Carry Forward Report and the Medi-Cal Transition Report. The Carry Forward Report is where consumers are being determined by their local county for Medi-Cal. However, Cover California will carry these folks on their same plan with any unchanged subsidies until Medi-Cal picks them up. This is a good opportunity to inform consumers who may not be aware of this transition. It's a good time to have this conversation. If there's income that needs to be updated or anything like that, again, this would be a good time for that. The Medi-Cal Transition Report is a report that goes the opposite way. In other words, those who are falling out of Medi-Cal and who were once delegated to your entity will show up on this report. This is a great way of ensuring continued health coverage because the county will not carry these consumers until they're picked up by Cover California or let's say an employer. And so reaching out to these folks on the Medi-Cal Transition Report is that much more sensitive, and we hope CECs take advantage of it. These reports are again being provided to the lead navigator. So if there's anyone on these reports, then the lead navigator, CCHI in this case, will be sending that information on to their subs. Now we'll take a look at the delegation process. Earlier this year, Cover California introduced a rapid delegation option for consumers and their enrollers, or the CECs. This is where an enroller can log into their CalHERS account, search for a consumer, enter the consumer's phone number. The consumer receives a code via text, so they would need a cell phone that gets text messages. Then they'll share that code with the enroller, and the enroller enters that code in the system, and now they're delegated to the case. A lot of little quick steps, a couple of minutes probably, and it should be a done deal. The new delegation tool will only work if there is a single active case in CalHERS. So if there's more than one case that exists, or more than one active case that exists, enrollers will need to contact the service center to be delegated. Excuse me. Speaking of dual cases, CECs are being strongly advised to take all steps necessary to avoid creating a duplicate case. A thorough search for the consumer using any and all of the information provided will help. We may even need to contact the service center in rare cases where a consumer says that they have or once had a Cover California case if we can't find the case ourselves. Duplicate cases can cause problems down the road for everyone involved. The worst possible outcome being that a consumer receives APTC on 2 cases, which they'll have to obviously pay back the following year on their taxes, and they're going to be very unhappy. Traditional options such as calling the service center are still available for consumers to delegate an enroller to their case. There's also that delegation only line for enrollment counselors is still up and functioning, but we hope it's rarely being utilized because we're hoping everyone is using the rapid delegation process. And also a consumer may log into their account to add or remove a delegation at any time. And at this time, I'm available for any questions or concerns that I may address or take back. My contact information is on the screen. And that is all I have. By the way, I will be sending a follow-up email with questions that I'm not able to address now, quick links for CECs and this presentation as well. Thank you.
Thank you, Khaled. Is there still a number for CECs when they have problems logging into Covered California?
Yes, so there's a couple of ways to get that resolved. One is through a phone number that you're talking about. I'm gonna write this down right now so I can get that out to you guys. And then the other way is basically through me. Not necessarily through me, but you'd send it to me, and that we can't log in or whatever the issue is, we'll send that to our certification team and get it figured out on what the issue is and get you to bypass that.
Great. And let's see, here's a question here in the chat. Is the delegation line open Saturdays?
Good question. Normally they're not. During open enrollment, there's a possibility, but I will check into that and get the follow-up email out as soon as possible, probably latest by tomorrow, so you get that information timely.
Great, because I know in the past during open enrollment, there were certain designated Saturdays that were
right.
That line was available.
Yeah, definitely. And obviously, again, the delegation line is still open and available for anyone who needs to use it. But just to reiterate, we're hoping that it's being used because we can't figure out we're having a barrier or an issue with the rapid delegation option, and not just resorting to the delegation line out of habit. The delegation option is quicker. Once you do it once or twice, you're going to be like, oh my God, why didn't I do this before? Instead of waiting 15 minutes, 30 minutes for, whatever it is for a delegation line. So, yeah.
Are there any plans to automate the turning off the insurance for Medicare eligible recipients?
So for Cover California to turn it off?
Yeah.
Yeah. So for the way it happens is I'm sorry, Medicare or Medi-Cal?
When they age, when they become Medicare
Gotcha.
eligible.
I got you.
Yeah.
Yes. No. There's no talk about having that done at this time. The only thing that we're looking into, I guess that's what you're referring to, is somehow making it automated with, not sure who controls Medicare, but if it's DHCS or whatever, but somehow making it automated. I don't think that's going to happen for a very long time because we can't automate things within our own system. There's certain things that we can't automate or that we're trying to automate, let alone having that happen with a outside department. And so it's a good idea. It's something that is in discussion. It's a small discussion because it's affecting a small percentage of consumers, but it's a conversation that's being had, but I wouldn't hold my breath for it right now.
Thought I'd ask. All right.
Thank you.
Thank you, Khalid. And do you have any flyers for the penalty? So
flyers for the penalty, I will look that up and I will also attach that in the email I'm sure we have something.
Okay, this is Melissa from Kern River Valley Family Resource Center in Lake Isabella, and she's a new program director. And I wanted to see how do I get someone trained for our office to be a navigator so we can help families in our community with Medi-Cal and Covered California. So
we want to become a navigator or a enrollment counselor, just to make that clarification real quick. We're trying to turn our entity into a navigator. Is that what I'm understanding?
I believe so, and then get their staff trained.
Okay. Staff training is always something that will happen and will assist you after the initial part, which is becoming a navigator. We were set to release our RFA next year, but I don't know if that's being pushed to the following year. But regardless, there's going to be an RFA coming up soon. And then that's the opportunity to apply to become a navigator. So one can get funding in one of two ways. Number one, you either become a navigator, you apply, get accepted, and become a navigator. Number two, you become a sub to a current existing navigator. Those are the two options. Obviously, if you're becoming your own navigator, all of the funding comes to you, whereas when you're a sub, it's shared funding, from up top. In order to become a navigator, one of the biggest things that the entity would need to do is to have a minimum of 286 enrollments, or more specifically, effectuations. An enrollment is when we enroll a consumer, but an effectuation is when the consumer makes that binder payment. So as we know, a lot of consumers may end up enrolling, but not making that payment for some reason, and that doesn't count as an effectuation. The reason why 286 effectuations is needed is because that's the minimum amount in order to receive the minimum grant of $50,000. And so if your entity is enrolling, let's say 50 consumers approximately year after year, the entity is very far off from the minimum goal. And then at that point, you would need to do some real convincing on your application in terms of how you're going to bump those numbers up from 50 to 286, 300 plus, so that we can consider you for to be a navigator. Hope that answered the question.
Sorry, I was on mute. All right, well, thank you, Khaled. Do we have any other questions? I don't see any. All right. Well, thank you, Khaled, and thank you everyone for presenting your programs to our CECs this morning. I think we're just going to go into announcements and then finish up the meeting. So if we have any announcements from the group.
Rodrigo, I just wanted to share with everybody that any follow-up items from this meeting, I will be sending out an email before end of day Friday to include any flyers or information that was left pending from this meeting to everyone in the network meeting.
Great, thank you, Argelia. All right. Any announcements from our group here?
And just quickly, I will be launching a poll right now. It's just an evaluation of today's meeting, getting some feedback from you all in regards to the session. So I'll be launching it. It's just 4 questions, so we appreciate if you would be able to answer them. Thank you.
All right, well, thank you very much, everyone, for participating. Wish you and yours a happy and Merry Christmas and a great New Year. We will keep hope as you know, as the pandemic kind of lingers on, but we're hopeful that next year will be a lot better and we can, you know, possibly meet in person, because I know we've been kind of been waiting for that moment to meet again in person. So thank you all for your patience, and I know Zoom is great, but nothing beats being there in person and actually seeing each other face to face. All right. Well, with that, I think we'll conclude our meeting. Thank you all for joining us.
Thank you so much, you guys.